Hi, this is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. And I want to welcome everyone today to the Journal Club for June. We're really very excited about this Journal Club and about discussing this particular article. Before we begin, I just want to mention a few housekeeping notes relevant to the Zoom platform for today's Journal Club. We're recording today's discussion, and the recording will be made publicly available. The participants with the cameras turned on may appear in the video recording. We ask that everyone please keep your microphones muted so everyone can hear the presentations and the discussions. And if you're having any difficulties or questions, please send a message in the chat and our technical support team will assist you. Definitely, as always, encourage time for questions. So please feel free to write your questions, submit your questions via the chat function throughout this session today. So as I mentioned, this month we have the lead article, Impact of Bilateral Oophorectomy on Survival Among Patients Undergoing Radical Hysterectomy for Cervical Adenocarcinoma, a National Cancer Database Analysis. We have the lead author with us today, Gabriel Levin from McGill University Health Center, Division of Gynecologic Oncology in Montreal, Canada. You can meet him in person if you're attending the IJGCS in Montreal this year. And certainly, again, I want to welcome you, Gabriel. Thank you for taking the time today, sharing your discussion and also sharing your answers to the questions that will come up from the audience and as well as the questions that our fellows have put together. So with that, I want to thank you for joining, and then I'll turn it over to you for your brief presentation. And I see a lot of familiar faces already. So I'm really glad to see former fellows and current fellows as well. So again, thank you. And Gabriel, the floor is yours.
Thank you, Pedro. Thank you for the invitation. And I want to thank the journal operations staff, the editorial fellows that joined us, all the audience. I hope there will be more audience. And I would like to thank my co-authors. There's a short list: Dr. Lucy Gilbert, Rene Pareja, Emily Leon, Ziggy Zhang, Ranan Mayer, and Reitan Ribeiro. Do you see my slideshow?
Yes.
Yes.
So cervical cancer is regretfully still a global challenge, despite being super preventable by efficient vaccination and screening. And in last decades, we see a high rise in the proportion of adenocarcinoma histotypes, up to 20-25%, and previously it was not. Historically, for adenocarcinoma, removal of the ovaries was performed due to concern of ovarian spread in apparently early cervical cancer. However, this old practice carries a significant impact on surgical menopause and is not based on any current literature. So we aim to study the impact of bilateral salpingo oophorectomy on overall survival of women undergoing radical hysterectomy, specifically for adenocarcinoma, but we also included other histotypes. And we performed a retrospective analysis of the NCDB database 2004 to 2022. We included women aged 18 to 45 with a specific diagnosis of cervical adenocarcinoma, and the exposure was BSO, yes or no. We also analyzed other histologies, squamous cell, and we compared groups by the exposure, and we implemented statistical analysis. And these are results. Overall, we analyzed more than 6,000 patients with adenocarcinoma, and 75% underwent BSO. The median follow-up for this analysis was 84 months, approximately 7 years. As you can see in panel A to the left hand of the slide, bilateral salpingo oophorectomy was associated with inferior survival in adenocarcinoma. 84% versus 87% alive at 15 years. As can be seen in panel number B for squamous cell histology, we included higher number of patients, and we identified almost 10,000 patients. The effect of overall survival was similar, with 83% alive versus 87%. For the entire cohort, which included more than 60,000 patients, including adenocarcinoma and squamous cell carcinoma, you can see in the middle panel the multivariable Cox analysis. And BSO was associated independently with worse overall survival with a hazard ratio 1.2, 95 confidence interval 1.04 to 1.36. On the right hand of the panel, you can see Kaplan-Meier curves of overall survival in the lowest risk group, adenocarcinoma, stage 1, no adjuvant therapy given. And you can see that overall survival was similar in both groups. What was strikingly, you can see the trends in the lower part of the right panel, the trends of BSO over the years. So you can see some kind of stability between 2004 and 2012. And after 2012, there is increased steep rise of 3% approximately each year, leading to a 90% of BSO in current days. So we can conclude that in this contemporary analysis of more than 6,000 patients with adenocarcinoma, BSO was not associated with improved survival, even after adjustment for significant factors. Among patients with the lowest risk of metastatic disease, survival was similar regardless of ovarian removal. And in this squamous cell carcinoma, and in the entire group, including more than 16,000 patients, BSO was associated with worse long-term survival, suggesting a potential harm. Despite these findings and the accumulating evidence, BSO increased sharply after 2012, exceeding 90%, indicating entrenched surgical habits rather than evidence-based decision-making.
Excellent. So, Gabriel, thank you very, very much for that summary. And as you mentioned there at the end, there are many who still propose and suggest that adenocarcinoma is a higher risk population, and they insist on removing ovaries and potentially in young women that will derive a harm from that practice. What would you say to somebody whose mind frame is ingrained in this concept that adenocarcinoma, you have to remove it at radical hysterectomy?
I would just say that he needs to be more paying attention to the evidence. It's like in the LAC trial. People don't believe that minimally invasive radical hysterectomy hampers survival and quadruples the rate of recurrence. But there is data. So it's not level 1 data. This is only a retrospective analysis, but it's not the only one. It's maybe the only one who is updated. And we see in an updated cohort that BSO is not associated with longer survival. On the other hand, we see an impact on longer survival with worse survival. So I just will lead him to read the data.
Yeah. Well, great. And I hope we will get a little bit more into as to why the increasing trends as well. But I definitely want to get to the questions from the fellows and then absolutely welcome questions from those in the audience as well. So our first question from our fellows, who will start with Eleonora Panisolo from the University of Padua in Italy. Eleonora?
Thank you, and congratulations to the authors. My question is, biologically speaking, if premature surgical menopause causes cardiotoxicity, metabolic harm, and accelerated frailty, why didn't this iatrogenic harm translate into a statistically significant survival detriment in the adenocarcinoma cohort?
Thank you, Eleonora. Well, indeed, the hazard ratio in our analysis was not significant for adenocarcinoma histotype, despite being significant in squamous histotype and despite robust evidence, as the UK Biobank study of more than 100,000 patients, the Cusimano et al. That I discussed in the podcast, and more than 200,000 patients, and the Nurse Health study, all indicating roughly similar hazard ratio of 1.4 increase in all-cause mortality. So how can we explain this paradox? And there may be several explanations. First, the median follow-up in our analysis is only 7 years, and the cumulative damage of premature menopause takes longer, is seen over a longer period of time. Second, and this is important, recurrent cervical cancer is not captured in the NCTB database, but recurrence of cervical cancer is lethal. These patients are quote unquote censored before premature menopause effects can be noticeable. We can assume that those who underwent BSO did it because of higher risk features, which might predict cancer recurrence. This is some type of selection bias or confounding by indication, where the BSGRU group actually loses its highest members before cardiovascular harm can accumulate. And finally, this is probably the most relevant answer, is that the study was almost certainly underpowered to detect this magnitude of harm in this specific cohort of adenocarcinoma, with the competing mortality from cancer and the trunked follow-up of only 7 years.
Excellent. Thank you, Gabriel. And a question that comes up with regards to adjuvant treatment and subsequent radiation, we'll turn over to Ana Conde from Madrid in Spain.
Hello, everybody. Congratulations for this great evidence in this topic. I am in National Cancer Database. We don't really have specific data about radiation field, so we don't know how many preserved ovaries were involved in the radiation field. So, if we found a young woman with risk factors such as deep stromal invasion or large tumor size, do you think it makes sense to preserve the ovaries, or maybe this radiation will negate the benefits of this preservation?
Thank you, Anna. This is a great point. We know that radiation dose of 15 grays is a sterilizing dose in women of 30 years of age. And this dose even decreases when there is increase in age, or if you use cisplatinum as a chemosensitizing in patients which are high risk as Peter's criteria. And we know that even a small dose of 2 grays is associated with significant ovarian damage. So should we do it? Should we leave the ovaries if we think we're going to give radiation? It's an excellent question. We know that patients with 1B1 cervical cancer negative nodes, the SOCR study, which was published in our journal, the rate of Stelli's criteria positive patients was 25%. So it's significant. LVSI, deep invasion, tumor size. So it's a substantial proportion of patients, 25%, need radiotherapy without chemosensitization. In this situation where you anticipate preoperatively or intraoperatively, we can have ovarian transposition actually.
Excellent. Thank you, Gabriel.
Perfect.
Gabriel, I'm going to turn to a question that I think came up during your review of the article and from one of the reviewers. And the question was, the clinical question is about bilateral ovarian removal and consequent loss of ovarian endocrine function. If the exposure includes salpingectomy alone or unilateral adnexal surgery or ambiguous removal of tubes and or ovaries, is the study not actually comparing bilateral oophorectomy against ovarian preservation?
Well, we don't really know we cannot capture all these details in the NCTB database, and we need to acknowledge the limitation of this database. We cannot go into very granular data. Too much confounders, recurrence yes or no, HRT yes or no, but we do know that the exposure to the best of our interest was recorded, BSO yes or no.
Okay. Let's turn over to, actually, Camila Luca is in a robotics course today. So I believe it's Anna who's going to ask her question. Okay.
Yes. Camila is sorry to don't be with us, but she wants to ask you about ovarian transposition. So she wants to know what is your, if you do it routinely for every patient, or if you don't only transpose the ovaries, if the possibility of adjuvant radiotherapy is high. And she also wanted to know if you have any observation about long-term viability of these transposed ovaries. Thank you.
Thank you for the question. It's an important one. To put numbers into context, in our analysis, approximately 20% of patients had postoperative radiotherapy, which is similar to the SUCOR database published at our journal. And the NCCN guidelines state that ovarian transposition should be considered prior to radiotherapy. So we know that high ovarian transposition, not lateral transposition, also published in our journal this year by the Canadian Ontario group, in 90% of patients with high ovarian transposition, ovarian function was preserved. So ovarian transposition, I see it as a considerable addition from my point of a young surgeon to radical hysterectomy, you need to dissect the gonadal vessels quite proximally to go enough to transpose the ovaries sufficiently high in the abdomen. And you need to tunnel them in the retroperitoneum, depends on your technique. So routinely, I would not recommend transposing the ovaries. I think it makes sense, though, to do it either as a second step surgery or in light of high risk feature, as you mentioned. Both options should be discussed with the patients. And it also depends on the availability of OR time. Is it easy to get a OR time for ovarian transposition? This should also be considered.
And Gabriel, as a follow-up to that, if doing ovarian transposition, is the norm and the standard in your practice to do bilateral ovarian transposition or unilateral ovarian transposition?
Bilateral transposition.
All right, very well. So again, please feel free to write in your questions in the chat. But next, we're going to turn to Costanza Saporano in San Raffaele in Italy.
Hello, hi. Thank you for your presentation. I have a question. So if a patient had her ovaries preserved and recurs, but not in the ovary, when starting her systematic treatment, would you consider going back to surgery to remove her ovaries?
Thank you for the question. The simple answer is no. If it's not an oligorecurrence or some kind of nodal recurrence, I would consider it a systemic disease, needs systemic treatment rather than a surgery. So recurrence, not in the ovary, systemic treatment, no surgery.
Okay, thank you. Thank you.
Excellent. And then now we'll turn to Alice Sampolini from Policlinico Gemelli in Rome.
Hi, hello everyone. First of all, thank you for your presentation. My question is, what would you do if you find an incidental cystic ovarian lesion during surgery? Would you leave the ovary? Would you perform cystectomy? Would you remove the affected adnexa? And especially, what factors would guide your decision?
And thank you. This is an intraoperative decision. All cases should be reviewed in tumor board prior to surgery, right? We review imaging studies, PET, and MRI, and we should know if there's anything anticipated or a suspicious cyst. On one hand, you can play it safe and remove it, and keeping the other ovary and avoiding premature surgical menopause to some extent. Keeping the ovary may have some sense, but not a lot. You should have a very good argument not removing a suspicious cyst right during surgery. If you're sure it's a functional cyst, it's a different matter, but you can never be sure 100%. I would err on removing the ovary, or in case an easy cystectomy is possible, you can consider cystectomy if you want, just to have it a future easier follow-up, so you know you left the pelvis without any suspicious anatomical landmarks that might be confusing in future imaging.
Excellent, very, very well. Question comes in from, I believe is Nico. Thanks a lot for the great study and the presentation. Any differences in survival in non-HPV related adenocarcinoma?
And by the way, Gabriel, congratulations for the study and thank you very much
Nicolo.
for the presentation.
Thank you, Nicolo.
Thank you. Great to see you all.
Great to see you, Nico. So, Gabriel, non-HPV.
Non-HPV. We didn't see, well, we analyzed HPV yes versus HPV not related cervical cancer, but we did not do specific survival analysis with BSO yes or no in the different subtypes. But we know that the ESGO guidelines recommends against ovarian conservation in HPV independent cervical cancer. And it's actually makes sense if we have a look at the gastric type. Quite rare, like 10% of the HPV independent, but the gastric type is super aggressive. We know that 30% have ovarian metastases. At presentation, all data, small series, but it makes no sense to conserve the ovaries in HPV independent from my point of view, and it's supported by the ESGO guidelines.
Thank you.
Excellent.
Congratulations.
Thanks, Nico. And perfect segue, actually, for Christina Kohler from Heidelberg University in Germany.
Hi, thank you. As you already mentioned, the gastric type subtype. Well, given that the registry could not perfectly isolate the gastric type adenocarcinomas, and those are known to have higher rates of brain involvement, as you already mentioned, well, is it safe to pool those histologies and make the or come to the conclusion that ovarian preservation is oncologically safe in early stage adenocarcinoma?
It was a perfect segue. Thanks for the question. Simpler answer is no. Gastric type is the main driver behind HPV-independent cervical cancer with the high risk of metastasis, 30%, right? However, it's rare. It's only 10-15% in the small series. So again, we have the ESGO recommendations against ovarian preservation in HPV-independent histotypes. This recommendation is pivotal. We have the gastric type, we have the clear cell, mesonephric. In these histotypes, I would not do ovarian conservation. And for this reason, we should not pool all adenocarcinoma histotypes into just a single small risk category.
Excellent. So, Gabriel, again, additional questions on the histotype. So this one comes from Albert Jacob, and he says, any current data on the incidence of ovarian recurrence, also any data stratified by the histologic type of cervical adenocarcinoma, and were there adenosquamous carcinoma cases in this database?
Thank you, Albert. Adenosquamous were gathered with the adenocarcinoma histology in our analysis. We don't have up-to-date data about ovarian recurrence in the different histotypes. Absolutely, we don't have anything updated with a large number of patients. So with this limitation of being a national cohort agranular database, I think it supplies us with the best knowledge that we can support our clinical decision rather than small cohorts of ovarian recurrence, yes or no.
So, Gabriel, we want to get now to this point and the issue about 2012 and what happened around the 2012 as you found in the study. So, first question, Chiara Ainio from the Mayo Clinic.
Hi, thank you very much for this interesting study. Yeah, so my question was, aside from the technical ease of MIS, what else was happening in gynecological oncology educational that might explain this collective shift towards more aggressive adnexal removal? And was it a change in how we viewed adenocarcinoma versus squamous cell carcinoma, or did institutional fear of recurrence simply peak during that era from your point of view? Thank you.
Thank you for the question. It's a very interesting question because you just look at the graph and you cannot understand what happened in 2012 and why specifically 2012, but the impact is doubling the rate of BSO. When you think of what changed during this period, I think two things. The first one is we see more increase in the literature of the proportion of adenocarcinoma histotypes. It used to be considered 5%. In the last 2 decades, the last decade, we see it's reported of proportion of 15, 20, in some series, 25% of being adenocarcinoma. So as surgeons taught upon BSO in adenocarcinoma, we see higher rate, possibly. The second thing that took practice in 2012, I would say the risk reduction salpingo-oophorectomy. This made us more aware of the options to reduce ovarian risk. You can see 2010, there is explosion of BRCA awareness and the literature about and recommendation about risk reduction salpingo-oophorectomy. So these are the two things that I think were the mains, plus the MIS era, the minimally invasive surgery created culture, institutional culture, high volume of surgical confidence, efficiency, just performing the agenda. Let's do it while we're here. Inside the abdomen, it's easy to do it minimally invasive surgery. This reinforced the ease of laparoscopic BSO. So eventually it's all added up, multiple reasons to remove the ovaries, more adenocarcinoma, let's prevent ovarian cancer, let's do it while we're here. And there was insufficient evidence to confidently preserve the ovaries. So it's like a classic example of how surgical practice defaults to more in the absence of some definite data showing less is safe. And for this, we have the new paradigm of de-escalation.
Excellent. So, Gabriel, staying on that same topic and what happened around 2012, Ezra, I believe, from Germany. it will pose the next question.
Thank you, Dr. Levin, for the presentation and congrats on the study. If the laparoscopic approach made surgeons more likely to remove the ovaries seamlessly, how would our surgical approach change now that the post-LAC trial area has pushed us back to the open radical hysterectomies? And the second part would be, do you predict that bilateral removal of the ovaries and Salping's rates will naturally decline back to the pre-2012 levels because open appendectomies require more complex dissection and or the hazard surgical habit would become permanently embedded? Thank you.
Thank you for the question. This is only a hypothesis in our discussion that things became more easier with MIS and incorporating more MIS in gynecologic oncology. And we actually see some kinds of paradox. 2018, October 31st, LAC trial, a drop in the radical hysterectomy MIS to less than 15%, but the rate of BSO in our radical hyst cohort is just increasing even after 2018. So it's just a hypothesis. And we actually have a national inpatient sample study by Matsuo and his group, found that MIS was independently associated with ovarian conservation. And he analyzed 2015, 2018. I think the route of surgery should not be a consideration for ovarian conservation. I predict that the BSO rate will decline, but not because of open radical hysts, hopefully because of efforts to promote ovarian conservation, as we're doing right now, the discussion highlighting the oncological safety that we present in our data. And this should be supported by the ongoing de-escalation paradigm and the ESCO guidelines, and hopefully national guidelines as well, to preserve ovaries when possible.
Excellent, very well. Gabriel, one of the questions from the audience is, can one potentially mitigate the adverse effect of an oophorectomy by just simply giving patients hormone replacement therapy afterwards? In other words, let's be cautious, remove the ovaries just in case, and then give hormone replacement therapy.
Yeah, thank you for the question. Makes sense, right? Just as you presented it. We know that by the estrogen alone study that giving estrogen or taking estrogen decreases the all-cause mortality. So it's absolutely feasible, but we also have data, large studies about the adherence to HRT or HMT. The adherence is not 100%, not 90%, and not 80%. It's difficult. You cannot predict it. You need follow-up. You need special consult for this. So theoretically, yes. Practically speaking, and globally practice, when there is different accesses to different formulations, some don't have gel, don't have patches, only oral, you can, but I wouldn't base the decrease in surgical premature menopause just basing on giving HRT.
Excellent. So next question, we'll turn it over to Kudus Lawal in Nigeria.
Thank you very much, Gabriel, for that presentation. Congratulations on this great work. Congratulations to you and your team, indeed. Given what the finding of this study have shown, how would you counsel a patient presenting with early cervical cancer?
Thanks, Kudus. Nice seeing you. I would counsel that ovarian preservation should be the standard, except for high-risk HPV-independent histology. I would go over the known data, the updated data, the risks of premature menopause. I would go over about the importance of HRT if we do BSO, and the importance of adherence to HRT taking. I would go over all the pros and cons as we usually counsel patients, just with more updated data.
Excellent. And next, we'll go back to Policlinico Gemelli, Chiara Innocenzi.
Thank you very much for all these insights on this study. So my question is, what restrictions regarding grade, size, or mandatory preoperative MRI or PET-CT imaging would our panel insist on adding before giving a green light? What's your suggestion on this?
Thank you. Before surgery, pelvic MRI and PET-CT are needed to evaluate the extent of disease, lymph node status, distant metastasis. I would adhere to the ESGO guidelines. The conservation of ovaries is not recommended for the HPV-independent adenocarcinoma, but regarding stage, grade, and size, I would not include them as a criteria. In cases when I think that I anticipate postoperative radiotherapy for intermediate risk groups, the set list, size, LVSI, I will discuss it with the patient and I will discuss ovarian transposition.
Excellent. Thank you, Chiara. And Gabriel, going back to the histotypes, what about other types? As an example, adenosquamous carcinoma, very rare, but again, that also has kind of fallen into this hypothesis that they are potentially more aggressive than the standard squamous carcinoma or even adenocarcinoma.
It's an excellent question, Pedro. We don't know the data. We lump them with the adenocarcinoma, but I don't think there's much literature to say that this HPV-dependent adenosquamous has more ovarian metastasis at diagnosis. I would practice the same practice as the whole cohort, as the squamous, as the adeno, as long as it's HPV-dependent, unless new data comes up. For now, I would consider it as a quote-unquote low risk or ovarian conservation is advised.
There seems to be already consistent data showing that you don't have to remove the ovaries at the time of a radical hysterectomy. Do we need any more studies? Is there a need for higher evidence-based for this particular topic, or is this a question that is settled and we need to move forward?
Excellent question. On one hand, I think you can run a surgical trial if you want with the volumes of cervical cancer we have with young patients with cervical cancer. I think you can run. So the question is who wants to run it and what is going to be the benefit. I think that clinical data available by now, and it's not just our group. Previous data, also by Jason Wright and Matsuo group, found that BSO hampers overall survival for these patients. So I think we have enough data to put it behind, to make it a prerequisite in each tumor board, cervical cancer, 4OR, we need to state BSO, yes or no, and we need to argue for BSO, and just go on with it.
Are there any other questions from the audience? All right, excellent. Any other questions from our fellows? Well, Gabriel, I want to thank you very, very much, obviously, for sharing and having this discussion with us. Very, very insightful. And again, thanks for submitting the article to our journal. I want to thank all of the fellows for sending in their questions and everyone who joined for the journal club. Really very, very empowering and important information. I also want to invite you to the July Journal Club to discuss successful bilateral sentinel lymph node mapping rate and empty nodal packet rate in uterine cancer from the group at Memorial Sloan Kettering. So look forward to seeing you there. For those of you who are going to ESMO GYN, enjoy Copenhagen. And then for the rest, again, continue to hopefully enjoy plans for a good summer. And see you at the July Journal Club.
Thank you so much, Pedro, and thank you all.
Thank you.
Thank you. Bye-bye.
Thank you. Bye-bye.
Bye. Thank you.
Thank you.
Bye.
Thank you.
Bye.